So Roger, when would you say IPF was first discovered? Did doctors before us know about it, or was it the CT scan, the first time we know about IPF? So thinking about why, when, what, where, kind of how different diseases happen, surely this disease didn't just happen in our lifetime. So Dr. Noth, when would you say IPF was first a disease that doctor recognized? Or anybody in the room have a comment about it? So it's hard to know, in part because we changed the names so much, and some of the names that Roger used and others, I think it's hard to be sure that what we call a disease is what doctors before us called disease. But one of the most revered physicians in America, at least, is William Osler. And in his textbook of 1893, when I looked at it, he described chronic interstitial pneumonia, interestingly with parentheses, cirrhosis of the lung. And his description was the gradual substitution to a greater or less extent of connective tissue for the normal lung. Somebody asked about collagen today. We know that connective tissue is collagen or the products of connective tissue. And he said, so diverse are the different forms and so varied the conditions under which this change occurs that a proper classification is extremely difficult. Roger showed the 7 different idiopathic interstitial pneumonias at the bottom of one of his classification slides. But I think this, in my mind, describes IPF. And it was interesting that he called it cirrhosis of the lung, as if that were a prior term. When you look back, actually, for cirrhosis of the lung, Dr. Corrigan in Ireland in the Dublin Medical Journal in 1838, so nearly 200 years ago, said that cirrhosis of the lung, this disease in the lung, is what cirrhosis is in the liver. A better name might be selected, but as there are already in medicine so many instances of names of diseases bearing no connection with their nature, I would rather add an additional fact than a new name to our science. And then went on, much like Dr. Osler described, the contraction of the fibers of the fibrocellular tissue obliterates the small air vesicles, on and on. The large bronchial tubes dilate. You saw that this morning on the CT scan, until at last the tissue of the lung diminished to a very small size, presents but a dense fibrocellular or fibrocartilaginous tissues. So this is many years ago. I believe this disease has been around a long time, and I suspect it's been in families for a long time. We just didn't have the tools that we have to recognize it today. Interesting to physicians, and maybe others, are that Dr. Laennec probably didn't get to cirrhosis of the lung. So I think he was immediately preceding Dr. Corrigan that I just showed you. So Dr. Laennec is famous, especially to respiratory physicians, because he developed the stethoscope in the late 1700s. But in his treatise of lung disease, just 10 years or 15 years before Dr. Corrigan, he said, I'm acquainted only with a small number of cases, and I think he didn't really recognize chronic pneumonia or something that was IPF at that time. So probably around the time of the 1830s or so. So you saw this morning, we talked about inflammation as a part in the treatment with anti-inflammatory medicines like steroids. And in fact, I believe most of that time from 1830 to about a decade ago or so, inflammation was thought to be the central origin of the disease, that the lungs became inflamed, maybe from some undiagnosed infection chronically, and that, in fact, the British called it alveolitis. That's the air sacs inflamed, cryptogenic fibrosing alveolitis, because of the emphasis on inflammation. But until about a decade ago, Anna Louise Katzenstein, one of the leading pathologists of IPF in Syracuse, said, no, guys, you have it completely backwards. The fibroblast focus comes first, and the scar, and then there may or may not be inflammation. And so I think there's an argument, and I think that's the prevailing opinion today, much of which you've heard about this morning. But the information I'm going to tell you over the next half hour or so, I hope reflects at least my opinion that both the fibroblast focus and the scar and the collagen that someone asked about this morning are results of the disease and are part of the body's response to what the true origin of the disease is. That's type 2 cell premature death and limited regenerative capacity. So I'll tell you what the type 2 cell is. The air sacs are just like branches on a tree to a certain extent, and leaves on a tree. Shown here is a schematic of the airway coming in. This is the blood coming back from the body in the pulmonary artery because it's desaturated. The oxygen's been taken out of it. It goes to the alveoli in the air sacs and gets oxygen and comes back into the pulmonary veins, goes to the left atrium and to the rest of the body. So there are branches, and then in those very small air sacs or alveolus, there are many cells. So the estimates are that there are 40 different cell types in the body. And one of those very most important ones is the type 2 epithelial cell that lines the air sac. It's probably the origin of the other cells in the alveolus, the type 1 alveolar epithelial cell. So these is a cross-section of the smallest air sac or alveolus. And shown here's the air tube coming in, the bronchiole, bronchus, and then the blood vessel comes in and goes around, and the oxygen moves from the alveolus into the vessel. So there are cell types, different cell types in the wall of the alveolus, the lining of the blood vessels, the wall of the blood vessel, the covering of the blood vessel, literally 40 different types of cells. So, and fibroblasts are basically the cells that are thought to produce scar. In a normal lung are poorly visible or absent. They're waiting there to heal scar or form scar under the right circumstances. But our evidence that I'm going to tell you about suggests that it's this cell type that has to be the origin for IPF, at least in some circumstances. And at the end, I'll tell you that those circumstances seem to apply to anybody who has IPF, not just in families. So literature about families with IPF starts probably about 50 years ago with Dr. Peabody in New York. And in 1950, he reported twins, two women who both at the age of 46, they developed IPF at age 43, both died at age 46, and they had lived apart for the last 25 years. So we knew about asbestosis and silicosis, a lot of the exposures that were related to lung disease before we knew about IPF as well. So this was important, he felt, to show that it wasn't something in the environment. They had lived apart for the last 25 years, yet they both still got IPF at the same age. And he wondered whether IPF might be a prolonged chronic affair, which remains completely subclinical until the respiratory reserve is depleted, and I think that has been confirmed in many studies now. And the following year, another physician in the same area reported a mother and daughter who both died of IPF. Transmission from parent to child is very important genetically. That tells you it's a dominant gene. The mother died at age 51 and the daughter died at age 39. And so those are two very important early reports of two people in the same family. So I don't know if this commercial has shown in your region as well, but Our Heroes Are Not Your Heroes is a Intel commercial that I was attracted to because the next slide that I'm going to show you is probably not your hero, but it's a TV commercial about A.J. Bott. It shows him dancing in to get coffee one morning at the Intel office, and he basically has rock star status at Intel for developing the USB port. So it seems inappropriate unless you're really kind of in the school that, that recognizes what a contribution that was to computer science. And so the same may be true for my hero, at least in IPF studies, is Dr. Phil Bonani, shown here in the left with a photo. I don't know if we can have the lights down in the front, and there's some slides later that might not show at all.